Hi everybody and welcome to my latest video about the future for myself with my condition. So when we get started, I'd like to say really there's two possible outcomes going forward. The first outcome would be if my campaign is successful and there are changes to the way that some chronic and acute pain sufferers like myself are treated, and the second option is if my campaign is unsuccessful or time runs out. So for option one, the future with that, assuming obviously that the campaign is successful and either I'm put in front of suitable specialists who are able to help me, or the GPs that I work with are given back their ability to prescribe the full range of medications available to them within the BNF book. So for those who don't know what the BNF book is, British National Formulary, it's basically the GP's handbook on all prescription medications that are currently available through the National Health Service. So in the case of option one, what will likely happen is that over a period of time my medication dosages will increase, and it's likely that I will be put onto other opioids. So for example, at the moment, as mentioned in the newspaper article, for those of you who were able to read it, and I will include a link to the new article in the comments section below. But I take Sevrodol, which is a brand name for morphine sulfate tablets, which means that under the current prescription system in the UK, the other options available to me that are stronger than that per milligram would be oxycodone, buprenorphine, and ultimately fentanyl. Now obviously these drugs have to be managed very carefully, and that's totally understandable. I obviously have to manage my morphine very carefully. So for example, I don't drink at all, I don't use any illicit substances, I am incredibly careful with how I manage them. But let's assume for a moment the campaign is successful and I'm prescribed the medications that my GP is saying that I need. What will happen is, over a period of time, my body will become more resistant to a certain dosage, a certain medication. We can then look to switch, because although they come from a similar family, chemically when you look at them they are slightly different. They're broken down slightly differently, so if you change over, even though it's a slight change, your body is less resistant to it, so you will get more effect, even if it's the same equivalent dose, just with a different medication. That would give me a significant period of time, probably several years, during which the pain could be managed a little bit better than it is now, even though my condition will deteriorate because it's the nature of Ehlers-Danlos syndrome, particularly my specific case of hypermobile Ehlers-Danlos syndrome. I'm putting a lot of pressure on my joints because of dislocations in other joints, so it's natural that I will deteriorate to an extent over time. However, the pain relief is probably the main thing that is keeping me from needing significant levels of care. So obviously with option one, I get suitable medication and it gives me a prolonged period of time where I can continue in very much the same manner as I do now. And obviously medicine does advance fast. I'm not expecting any massive breakthroughs with Ehlers-Danlos syndrome anytime soon. However, there is a little bit more focus going on to pain management and things like that, and it's possible that in a couple of years time there is an entirely new family of medications, pain relief, that is not opiate based, which would then give people like myself even more options going forward. The more difficult of the two to talk about, being very frank with everybody, is option two. Option two is basically where I'm currently headed if there are no changes. So assume that my campaign changes nothing. The newspaper article, the YouTube videos, the fundraiser, and all the other bits and pieces that I'm working on, including, for example, my Ehlers-Danlos related t-shirts and tote bags, again, which are a link below. In that situation, and I can only repeat what I've been told by the doctor here, my Ehlers-Danlos will continue to get worse. My resistance to the pain relief I currently have will increase. As that resistance increases, there will come a point where the risk-benefit ratio from the doctor's point of view is no longer in my favour. So at that point they would look to withdraw the medication. When the medication was withdrawn, I would be, as effectively call it naked, in inverted commas, or basically chemically naked against the ferocity of the pain from the dislocations. I would also likely, because of the side effects of other medications that wouldn't be balanced out by the side effect of the Sevrodol, I would also likely have to give up other medications which actually help with the chronic pain. So the gabapentinoids and the duloxetine and things like that. Now, as the GP said to me in the conversation 2 months ago now, when the medication is withdrawn, my disability will get significantly worse, because obviously the medication is at the moment one of the main things that sort of keeps me as capable as I am, although I am severely limited. It gives me the ability to do more because I'm able to resist the pain more. So the conversation would immediately become about care. Now, in the UK, and particularly in Scotland, the emphasis with care is to try and keep the patient in their own home, because one, it's better for them emotionally and mentally and even their health, but it's also cheaper. If we're going to be brutally honest here, it's cheaper. Now, in my case, as the GP has said very honestly, and with my personal experience of the care system, it would be very, very difficult to keep me at home if I'm going to need help managing the dislocations, because I no longer have pain relief to help when I've got, let's say, 7 or 8 or 9 or 10 dislocations at once. So in that situation, there would be a conversation about inpatient care at some kind of facility. Now, obviously, your kind of average, your regular care home really only takes people sort of over the age of 65. Sometimes they'll go down to 60 or so when there's a medical reason, for example, like somebody suffering with dementia. So I would be looking at some kind of NHS facility, of which there are not many in Scotland or in the UK as a whole, because I would be needing effectively round-the-clock medical help to manage the dislocations. Now, one of the cruelties of that situation is that, unless I fall awkwardly and bang my head or end up with a hospital-borne infection or something like that, I have the ability to live into my 90s, maybe even make it past 100. Now that, considering I'm 31 at the moment, and I will be 32 in basically a month's time, that is a very long time, 30, 40, 50 years, to ask somebody to manage that number of dislocations, and that's assuming that number doesn't increase, which it's likely to as other joints get involved. That's a long time to ask somebody to manage without pain relief, and manage with that number of dislocations, and manage with that level of care and things like that, because obviously my situation is not affecting my cognitive abilities, and I personally find it very difficult mentally and emotionally to think about living in that kind of facility. I know the staff there in those kind of places. I've seen documentaries on those kind of institutions for people with acquired brain injuries, for example, and the staff are really passionate and they work really hard and they care for the people that they look after, and they do the best they can to make it as comfortable and as lovely for them as possible. And they have my absolute, unyielding, undying respect for that. For me, it's a personal issue. I've kept fighting to keep myself as independent as humanly possible, despite the massive difficulties that Ehlers-Danlos loss and the dislocations and the pain that results. Despite the impact that has on me, I do everything I can to try and stay independent, and losing that independence because of medical need is something that I'm obviously not overly keen on. So those are the two options for me. Option one is some positive changes come up, people like myself, because I can't be the only one in Scotland. I can't be the only one who's got a difficult chronic pain situation that does not fit the one-size-fits-all approach that's currently practiced by pain units, like the pain unit I've experienced with NHS 5. Obviously, with me not being the only one, I'm hoping that any changes positively benefit other people as well. But obviously, if I can get option 1, then that's fantastic. It gives me a period of time where I can continue working, continue fighting, continue campaigning, continue trying to do the best I possibly can to improve the situation for chronic pain sufferers in the UK and disabled people at large. Or obviously, if nothing changes, then we have option 2, as has been discussed. So that really is my kind of future as things stand at the moment. Obviously, I'm hoping that it's going to be option 2. I'm sure everybody watching this, I hope it's going to be option 1. I'm sure everybody watching this is hoping it's going to be option 1 as well. I'm sure some people watching this may very well have a family member in a similar position and are hoping it's option 1, because as soon as one patient can get that kind of treatment, it opens the door for others, and that would be the best outcome. And if we speak frankly for a moment, everybody, none of the medications that they could prescribe me are expensive. They're all what we would call generics. The patents on them have run out. They are very cheap to manufacture, very cheap to distribute. We're talking a few pounds a day at most, and possibly significantly less. It's a lot cheaper to give me the medication and give me a couple of years with more comfort and more independence than it is to put me into a care situation. And that, as awful as it sounds, I hope that factors into their thinking as well, in that we can pay more than it costs to imprison somebody in the UK to keep him, or we can pay a couple of quid a day, and at the very most, and if necessary, I'm happy to pay that extra cost myself. I don't have a lot of money, I don't have a lot of funds, but this is one of the things I would prioritise, and I would obviously fight for it myself. So that's an explanation as to what my future looks like currently. It's based on the conversations I've had with medical professionals recently, so this is not just me kind of plucking it out of thin air. And what I'm looking to do in the next video is talk about the campaign, and obviously we've talked about it a bit already, and a little bit about the aims and objectives and goals and things, but I really want to kind of make it crystal clear for everybody how I'm fighting the campaign, how I'm going to keep fighting the campaign, how I've started it, the direction I'm looking to go, and what I'm hoping to achieve. I'm also going to mention how the watchers of the video can get involved in the campaign and fight and try and improve health outcomes for the group of people, including myself. So thanks very much for taking the time to watch the video. I'm incredibly grateful, and if at all possible, everybody, keep your fingers crossed for option 1, because I'd certainly prefer a couple more comfortable years and that giving opportunities for new things to come along. Thanks very much for your time, and I will catch you soon in the next video.